Hello everyone, my name is Jessica Breezy and I am a nurse practitioner working in the Stroke Prevention Clinic at the Royal Victoria Regional Health Centre. This 10-minute video is intended to introduce you to the changes in the Stroke Prevention Clinic referral form and the related changes to best practice. First, I'd like to review important evidence regarding TIAs and provide you with the reasons for updating the referral form. There is clear evidence that TIAs or minor strokes are unstable conditions that warn of high future risk of stroke. The risk of recurrent stroke after a TIA is 10 to 20% within 90 days, and the risk is front-loaded, with half of the strokes occurring in the first 2 days following initial symptom onset. Timely initiation of secondary prevention medical therapy and carotid endarterectomy has been shown to significantly reduce the risk of major stroke after an initial TIA or non-disabling stroke. This is the referral form you would all be used to and is being discontinued because it was based on the ABCD2 criteria, which was the most validated tool at the time, but is no longer recommended by the Canadian best practice recommendations. The ABCD2 criteria tended to overappreciate risk in patients over the age of 65 and underappreciate risk in younger patients. There were also no points assigned for posterior circulation symptoms. Additionally, the referral form change was further prompted by the many inappropriate or incomplete referrals received in the SPC, and there were no clear recommendations for minimum diagnostic investigations on this form. Finally, the best practice recommendations from the 2012-2013 cycle stated, all patients with suspected TIA should undergo brain imaging immediately and vascular imaging of the brain and neck arteries within 24 hours. As we examined stroke prevention clinic flow and capacity with the broad stakeholder group, we were challenged by our DI partners. Did all potential TIA patients really need vascular imaging within 24 hours? Conveniently, around the time of our SPC review, the best practice guidelines were updated and the Ontario Stroke Network triage algorithm was developed. You will notice one major difference compared to the 2012-2013 recommendations. Patients are clearly being stratified by risk category, and essential investigations and timing of assessments are recommended according to this risk category. Research tells us that the patient population highlighted in this blue box is at the highest risk for subsequent stroke. High-risk patients should be evaluated within less than 4 hours from referral date, should be referred within 24 to 72 hours. This evaluation involves rapid assessment and immediate access to investigations and can occur in an emergency department or in a stroke prevention clinic that can accommodate same-day appointments. Other risk categories will be further explored when we walk through the form. Patients are currently assessed in the stroke prevention clinic Monday, Tuesday, and Friday from 8 to 12 and Thursday from 8 to 4. Referrals are triaged 8 hours per day and 5 days a week. For this reason, it is a challenge to accommodate same-day appointments. This referral form lists the essential investigations recommended to occur in the emergency department to best meet the needs of the patient based on their level of stroke risk. It is important to note that the Stroke Prevention Clinic is now involved in a quality improvement initiative that has significantly improved wait times. So this is the first page of our revised stroke prevention clinic referral form. I wish to emphasize that the empty boxes in the essential investigations section should be used as a checklist to verify that these things have been done. This will also serve as communication to the stroke prevention clinic. It is not intended to use as an order list, and essential investigations are not optional. You will notice that there is no time frame written on the referral form, as it was felt that this would make for a lengthier and potentially more confusing form. It was felt that the SPC triage would further determine the level of risk based on the time frame listed by the referring provider. It is of crucial importance that our referring providers recognize high-risk symptoms and know what to do with them. So I do apologize for the small writing here, but we are going to go through each category in greater detail. Patients in the high-risk and increased risk population present to the emergency department within 24 to 72 hours of symptom onset. which may include unilateral motor weakness, hemibody sensory loss, speech difficulty, and/or vision loss. To be considered at highest risk, hemibody motor weakness may be in one body segment, so the face, arm, or leg. Sensory loss must involve at least two contiguous segments, the face and arm, or arm and leg. To be considered highest risk, the TIA or stroke symptoms are consistent with a side of known untreated moderate to severe carotid artery stenosis, or greater than 50%. In this case, vascular surgery should be immediately consulted. The referral to the stroke prevention clinic will still be triaged as high risk, but the priority is the vascular surgery consultation. The high-risk category is also designated for TIA or stroke symptoms that occurred in a patient with known or newly documented atrial fibrillation that is either not anticoagulated, subtherapeutic, or suspected to be subtherapeutic. The essential investigations and the timeliness of completing these investigations are based on the Canadian Stroke Best Practice recommendations. Consider endarterectomy for symptomatic carotid stenosis. To yield maximum patient benefit, the goal is to operate 14 days from symptom onset. As an example, a patient was seen in the emergency department on a Friday evening, had a CT head only, and was referred to the stroke prevention clinic. The referral would be processed on Monday, and the patient will be booked at the next available appointment. Best case scenario, they can come in within 24 hours. 5 days have now elapsed, which could have been prevented if the imaging was done immediately, as indicated on the form. Understanding the implications on the diagnostic imaging department, CT angiogram was listed as an essential investigation for the highest or increased risk symptoms only. The Torbest swallowing screen is recommended for symptoms that persist or fluctuate. This may serve as a prompt for the referring provider to consider admission for patients with symptoms that persist, and to ensure we aren't sending patients home that cannot swallow. To recap, the essential investigations for high-risk patients are CT head, CT angiogram is preferred, and if this is contraindicated, a carotid Doppler could be completed, ensuring that this is completed within 24 hours. 12-lead ECG and stat blood work that you see listed here. Patients in the intermediate risk category may present to the emergency department with less obvious signs of stroke or TIA, especially if they occur in isolation. When a combination of these symptoms occur, posterior circulation symptoms should be considered, and a note is made to this effect in the investigation section, specifically with the recommendation of a CT angiogram. The stroke prevention clinic would also accordingly assign a higher risk category with symptoms highly suspicious of posterior circulation ischemia. A CT angiogram is only recommended if 2 or more of intermediate symptoms are present to better assess intracranial and extracranial vessels of posterior circulation. Lower risk doesn't mean to suggest no risk. These patients still require assessment. This risk category captures more vague, non-specific symptoms such as tingling, asymptomatic carotid stenosis, or abnormal brain imaging in the absence of focal neurological deficits. This category should also be applied for patients being discharged from an inpatient setting. Even if the patient was admitted to hospital with high-risk symptoms, the risk category is lower because the patient should have had all essential investigations completed during their hospital stay, and a diagnosis is usually established. The patient may be given a higher priority if cryptogenic stroke or a complicated case requiring more urgent follow-up. At minimum, a CT head should be completed. Forwarding relevant consultation reports and other diagnostic investigations will also be helpful. The second page of the referral form is just as important to complete as the first and aligns directly with best practice. The first box highlights the information needed to assist the stroke prevention clinic process the referral. There is a note made to refer the patient to vascular surgery if there is symptomatic carotid stenosis greater than 50%. This box highlights antithrombotic recommendations once the initial CT scan has been reviewed and there is no evidence of bleeding. If the patient has newly discovered atrial fibrillation, or if the patient is subtherapeutic on warfarin, initiation of an anticoagulant is recommended, provided there are no contraindications. Finally, we have recommended discharge instructions that should be completed as a minimum in the emergency department. In summary, we have a revised stroke prevention clinic referral form that we all encourage you to use, and that means that the former referral form will be discontinued. Importantly, the level of stroke risk is based on the patient's symptoms and time of onset. The timeliness of investigations are determined by the level of stroke risk, and these essential recommendations are not optional. We encourage you to view the referral as a documentation and communication tool as opposed to an order set. Fully completed forms offer the greatest information for the stroke prevention clinic to process the referral and is best practice for the patient. If you'd like to have more information on the practice that supports this referral form, we encourage you to take a look at the Canadian Stroke Best Practice Recommendations with each of the hyperlinks listed here. There are also additional webinars available through the Central East Stroke Network website, or you can contact Kay Morrison directly for opportunities for one-on-one interaction.